my friend and colleague, Dr. Paul Dasari, he did his endocrine fellowship with us here at OU, and after completing, has been working in the Oklahoma City Indian Clinic and developing a program within that not-for-profit clinic and clinical setting. He also has his master's of public health and has really focused his practice around obesity and diabetes in youth, especially in a unique population that we have here in Oklahoma. And so wanted him to have the opportunity to share about his unique practice. Dr. Dasari.
Thank you, Dr. Triggerstead, for this opportunity and giving me a chance to present about what I do out in the community. My topic today is endocrine care and Native American communities. And being the last speaker, I have two advantages. One, you guys are so done for the day, so you probably won't pay attention. And I probably don't have a time limit, so. All right, moving on. I have no financial disclosures. Even though I work with a lot of grants at our clinic, I am not directly paid through a grant. So learning objectives for this evening, to summarize a brief history of Native American health, to identify disparities that exist in Native American healthcare, and to describe the healthcare for American Indians in Oklahoma, mainly focusing on Oklahoma City Indian Clinic. Moving on to my first objective, we'll briefly see the first two objectives. I'm going to spend very little time focusing more on the third one. But moving on to the first one, summarizing the brief history of Native American health. First, I wanted to kind of go over the terminology. Most of us know who Native Americans are, but they're basically a member of any indigenous people of North, Central, and South America, especially those indigenous to what we now know as continental United States. They are also referred to as Native American, indigenous peoples, First Nations, Alaskan Natives, or American Indian. There are about 574 federally recognized tribes, out of which 38 are primarily located in Oklahoma. Pre-colonialism, American Indians lived off of the land. They had a very active lifestyle. They were hunters, gatherers, and gardeners. Their lifestyle included having a high fiber diet, a high physical activity, and a lot of lean protein. After the colonialism ended, and then we have this map which has those 38 tribes that I was describing, there were certain health consequences. The American Indians were not prepared with the Oklahoma area or the topography of it. The food rations were given twice a month, which included lard, flour, coffee, sugar, canned meat, and it created a dependence, now known as commodities. They had lower physical activity, and the fiber content in their diet had come down significantly, and they had a high fat diet, and which resulted in a total lifestyle change, high physical, cultural, emotional, and social trauma. That leads me to the segue of identifying the disparities that exist in the Native American healthcare. Coming to the social determinants of health, we see that when it comes to income and wealth, most Native Americans are economically impoverished. Their median household income is about $37,000 compared to $53,000 on an average. Education-wise, they have the highest high school dropout rate and the lowest high school completion rate. Housing, they have an excessive house cost burden, and they don't have safe or reliable water in most of the households. A lot of their households are overcrowded, 11% compared to 3.1% in the rest of the US households. And even though 71% of Native Americans live in urban areas, there is a high degree of racial misclassification that impairs the data collection in terms of the mortality rate. They have less access to hospital systems and clinics. Coming to public safety, Native American women have about 2 times more likelihood to have experienced a violent incident in their life. Native American men have about 1.3 times. They have been arrested more than about 1.5 times compared to the rest of the population, incarcerated more than twice compared to the rest of the population. They have an elevated risk for delinquency and incarceration, and more likely to live in poverty, drop out of school, as we just talked about, exposed to violence in youth, and twice as likely to be arrested and twice as likely to be detained after they are arrested. When we see patients in our clinic, almost 90% of the households have two parents. Less than 90% of the households have two parents that come to the visit, most often taken care of either in foster care or by their grandparents. Leading causes of death, heart disease, which is pretty similar to the rest of the US population, cancer, but diabetes comes in third. It's usually about fifth or sixth when it compares to the rest of the population in the US, and the unintentional injuries is also pretty high. Again, mostly related to the social determinants of health that we just talked about. Life expectancy is about 5.5 years less than the general population. And when it comes to the endocrine statistics, Native American adolescents are 30% more likely than non-Hispanic whites to be obese. And Native American adults are about 50% more likely to be obese than the non-Hispanic whites. Increased blood pressure, cholesterol, diabetes, all risk factors for heart disease and stroke. Of course, the incidence is pretty similar to what it is in general population, but they're at a higher risk for these comorbidities. Of course, insulin resistance is pretty high. The number of kids I see with acanthosis is a lot, as young as 2 or 3 year old kids who come in with insulin resistance. Moving on to the third objective, I'm going to describe the healthcare system in American Indians, mainly focusing in Oklahoma. The American Indian healthcare system is broadly classified or divided into three parts. We have the IHS, which is Indian Healthcare System. They have their own clinics and hospitals. And then we have tribal clinics and hospitals, and then urban clinics and hospitals. Our clinic is one of the urban clinic in Oklahoma, the other one being in Tulsa. The mission of the Indian Health Services is to raise physical, mental, and social, along with spiritual health in American Indians and Alaskan Natives to the highest level. Their vision is to have healthy communities and quality healthcare systems through strong partnerships and culturally responsive practices. And their strategic goals kind of sum up what their mission and vision is. These are the different IHS offices across United States. There's one in Oklahoma City, as you know, it's on Market Drive Street in Edmond. We are very strongly affiliated with them. They help us out a lot in a lot of the referrals that go out through the clinic and pay for them as well. These are the ones that they're affiliated with in Oklahoma. It's a busy map, but just wanted to kind of give you guys an idea. Talking about Oklahoma City Indian Clinic, where I work at. Oklahoma City Indian Clinic was established in 1974 at a storefront location in downtown Oklahoma. In 1969, so just a few years before it was actually established, a group of volunteer physicians came in together, and they provided free 5 hours weekly service to underserved American Indian population. And at that time, the closest American Indian healthcare was about 40 miles away, and the hospitals were about 2 hours drive. So in 1974, the American Indian community leaders, physicians, and clergy petitioned the US Congress, made appropriations to address the healthcare access barriers, and then formed the Central Oklahoma American Indian Health Council, also known as the Oklahoma City Indian Clinic. It moved to a 7,500 square foot storefront location in downtown Oklahoma City. They actually witnessed the Oklahoma City bombing when that happened. They were working that day when it happened. And over the next 20 years, the clinic grew to a staff of about 38 full-time employees, including 2 full-time providers, a pharmacist, and a dentist, mostly providing adult care, very little pediatric. So they then moved to this location in 1995, where they needed more space. This is called as the Corinne Y Half Moon Medical Building. It's about 27,000 square foot building. Its staffs, they had enough staffs to provide services for about 35,000 annual visits, and which accounted about 200 to 300 visits per month. But they were constantly growing. So in another 20 years, they outgrew that space. So that's around the time when I joined the clinic, when they moved into this space. In addition to the original location, they built the Everett Roads building on right across the street from the main clinic building. And this facility houses behavioral health services, health promotion, disease prevention department, public health, physical therapy, wellness center, diabetes education classrooms, including a kitchen for demonstration, and a Harmony pediatric clinic. In 2018, they bought another building across the street, just that one, that they expanded more services in that, and also opened an easy access clinic. So these are our goals. Our vision is to be the national model for American Indian healthcare, and our mission is to provide excellent healthcare to American Indians. We have 4 core values that we go by, which include people first, quality, integrity, and professionalism. And our CEO's initiative, that's from 2022, but we should be having our strategic plan coming out for 2023 this month. But we are very focused on looking at things through the lens of the customer. So providing services to our patients based at their level. And as I've shown, the disparities, the patients that come to see us are very poor, lack a lot of opportunities. So it's very important to come down to that level. In the next few slides, I'm going to show you a few things that we do at our clinic that will kind of emphasize on that. Our CEO's 10-year goal is to have a hospital and all other services, including what we have right now. In addition to that, to provide women's health care. Right now, we do have a OBGYN department, but we can deliver babies, obviously, in an outpatient setting. So we have affiliations with the Chickasaw Nation Medical Center in Ada, as well as Integris Healthcare System to deliver our babies. So the goal is to have all of that in one campus in 10 years. We do have national level partnerships. As I had mentioned, all the programs that are provided through our clinic are free, and so somebody has to pay for it. So we get grants. A lot of money comes through national grants. The ones that are pertinent to this talk and the group are from CDC, which is the GWIC and the TIPWIC grant. These 2 grants have helped us immensely in designing and implementing a lot of pediatric as well as adult obesity programs and prevention of type 2 diabetes. We do have a grant through OMH, which is Office of Minority Health, and through that we are able to provide additional services to our type 2 diabetes patients. SDPI grant, I don't know if you guys are aware of this one, but it's one of the largest grants in the last 20 years that our clinic has been very fortunate to get. It's special diabetes program for Indians, and this provides a lot of incentives to our patients, be it gas cards to come to the clinic, to the appointments, or to get their health care. The last one that we got about 3 years ago was AstraZeneca Foundation grant, which helped us provide healthcare to prevent hypertension, take care of patients with heart disease, mainly focusing on hypertension and heart disease. We do have a partnership with the Native Youth Preventing Diabetes Coalition. This was formed about 20 years ago with a lot of tribes. Our clinic, IHS, universities, and the Southern Plain Tribal Health Board. And it's a 20-year pediatric wellness camp. This happens once a year in the summer, where all the kids spend about a week learning about preventing diabetes and healthy lifestyles. We have published successes from these camps. We have direct partnerships with Cheyenne and Arapaho tribes, and have mutual givings that we have. We have networking with them. They do provide bison meat to us for our cooking classes that we give out to our patients. And we have speakers come and talk at our events that we have. The Chickasaw Nation has a strong affiliation with our clinic as well. They do provide their facility for our annual retreats and other things that we do with our patients. They send their students to our clinic for preceptorship and internship. I do have their medical residents coming in from their family medicine residency program to rotate with us and learn stuff from us. And then we have direct partnerships with the Delaware Nation. They provide equipment and expertise, and they also fund a lot of our kids' camps. And then we have the Muskogee Nation that provide cooking class instructions, educational tools, and they have a lot of facilities that we use for our programs as well. What did we get, or what do we do with these tribal partnerships? The program longevity, like I said, the Native Youth Preventing Diabetes Coalition, we have had that for 20 years, and the Oklahoma Intertribal Diabetes Coalition for 15 years. And then, all of these things that I mentioned up there help us design and implement all these programs and help our patients. We have a lot of community partners. I'm not going to read out all of these, but quickly go through. I just listed them out. Some of these might seem familiar to you all, but all of these affiliations help us run a lot of our summer programs. I'm going to show you a few pictures of them in the next few slides. These are the brochures that our patients get based on the time of the year. This is our spring 2022 programs list. You just scan the code and sign up for the program. All of this is free for our patients. They get to choose which one they want to attend. A lot of these are also after school programs. We do understand kids have to attend schools, and in order to promote healthy lifestyle to them, we do have to, target the time that we have after school. So our staff stays up till 7 o'clock in the evening to run these programs with our kids. There are a wide variety of them, as you see. Summer is our busiest time. We have a lot of programs starting in May that run through the end of July when the kids go back to school. We also have kids camps that we have at the beginning of school year to do sports physicals, and we use that opportunity as well to introduce healthy lifestyles and all the programs that we have in our clinic. This is our fall brochure for the last year. We should be coming out with the spring one for this year pretty soon. So the endocrine team, I'm been there for almost 10 years now. We have an adult endocrinologist, Dr. Michael Breyer-Ash. A few of you might know him. He recently joined our practice. We have our respective nurses. We have a registration assistant who helps her schedule all our patients. We have 7 dietitians, 2 pediatric and 5 adult dietitians that work with our patients. We have an integrated pharmacist that helps with these patients who have complex medical histories, mostly for the adult endocrinologist. We do have an integrated behavioral health therapist who works with our patients to address any mental health issues that we have on an ongoing basis. We have 2 case managers. We have a certified diabetes educator. The special part of our clinic is we have our own gym that our patients can come and work out, and we have 7 certified personal trainers that you can work with them for free. We also have a certified lactation consultant program. I'm going to talk a little bit about that here in a minute, that provides services for our pregnant. We start these programs when we have pregnant patients, and then work with them through delivery and breastfeeding after that. Patient care. Most of our patients that we see are through internal referrals. Our primary care providers, as well as nurse practitioners and physician assistants, are the ones who send us referrals. We do get external referrals from IHS. As I had mentioned, we have a very strong affiliation with the IHS system, so we do get referrals from outside. All that our patients need is a CDIB card, which is a certificate of degree of Indian blood. You need a birth certificate and an SSN. There's no wait time to see any primary care provider. Referrals are usually seen within the month based on the equity of the situation. We have our own pharmacy and give out almost all of the medications. We are restricted in terms of the kinds of insulin that we give out. We just have 2 choices, Levemir and Novolog. Anything else that has to come other than that, we have to call it into an outside pharmacy. But most of our patients are okay with that. We have our own X-ray, CT scan, and an DEXA scanner. We have our own lab as well. And all of this is free for our patients. Coming to the departments that come under the Metabolic Care Center, we have our health promotion, disease prevention, where we provide one-on-one counseling for nutrition. All the after-school programs that I just mentioned on those brochures are run by our dietitians and our trainers. And then we have a pediatric wellness program. I'll talk a little bit in detail about that here in a minute. We have a BRAID team. This is a national program being responsible for American Indian diabetics. Basically, patients who have been diagnosed with type 2 diabetes are under this program. They get a lot of care in terms of getting their glucose monitors, their test strips, their education. All of that is under this program. They have several programs through the year that they attend where they get to learn how to do healthy cooking and exercise in our gym. Then we have the STAR program, which is steps taken to achieve reduction. This is mainly for adults with pre-diabetes. That the focus is to help these pre-diabetic patients to manage their pre-diabetes and bring them back to normal BMI or a normal A1C level. We have a fully equipped gym with certified personal trainers, like I mentioned. Anyone who is 12 or older, including young adolescents and children, can go in there. They do need an adult to be present between the ages 12 to 16 to work out with our trainers. But we also have a kids fun and fit gym that is catering to the needs of patients who are less than 12 years old. And again, we have personal trainers who is specialized in pediatrics that works with these patients. And then we have a smoking cessation program. We are affiliated with our state health department, who helps us quite a bit with this program, but our integrated pharmacist is the one who runs this program. They do give out nicotine patches, gums, and other supplies that are needed for this program. Mostly needed for our adult patients, but we do see quite a few of our adolescents that need this program as well. That's our gym, and that's our kitchen. It's a fully equipped kitchen where they have a live demonstration. Unlike our Food Network shows, we actually get to taste what they make. So it's good. I've attended quite a few of their classes myself. The goal of this kitchen is mainly to replicate what we eat on a regular basis and make it healthy. So, and I'm going to show you a few pictures of what we do with our kids in a minute, but this is a very popular location in our clinic. I've already talked about the BRAID at the STAR program, but the last one on there, it's called as the Get Set, which is Screening, Education, and Treatment Program. It's an 8-week program that we do 4 times a year, where our patients get to work out with our trainers. That's Matt right on the bottom. He's the head of the wellness center, working with one of our patients. That patient actually lost about 200 pounds and even came in through the pandemic to work out. So, and all of these, and of course, all of these patients have signed our disclaimer form to be on this presentation. So, but the Get Set program, going back to that, it's an 8-week program where they come and work out. They have to come to the wellness center or show proof of working out at an outside gym at least 4 times a week, and then attend one of our cooking classes a week. And then in addition to that, if they attend a one-on-one nutrition class with a dietitian, they get stickers for each of these participation. And if they make certain number of stickers over a period of 8 weeks, they get a gift card. It used to be a Nike gift card. Now they've changed it to Academy Sports so that you can just buy whatever brand you want. But it's a pretty good sizable gift card. It's almost $50. You can make up to $50. So it's a good motivation for our patients to come in and be there. Most of these patients, I know a couple of them who actually come in also for social networking, because they all attend these classes together. It gives them motivation and to come and be healthy as well. Coming to our dietitians, these are the things that our dietitians mainly work on. There is one-on-one counseling in addition to all the after-school programs that we do. Food introduction, there's a program that one of our pediatric dietitians does is through ages 2 months and above. I know young babies don't start eating solids until 5 to 6 months, but we start introducing that concept of healthy eating right at the beginning itself. And it's called as the food introduction program. Then we obviously talk a lot about overweight and obesity prevention. We also deal with underweight. All of our dietitians got certified in seeing patients with anorexia last year. So that's the other spectrum of the disease process that we see as well. They have a constipation clinic in our clinic as well. So a lot of GI issues are dealt with that. And then, of course, we have patients with diabetes that they provide education about. Our certified lactation consultants, we have what we call it as a CLC hotline. Our patients, most of them who are breastfeeding, as you all know, breastfeeding has a lot of studies associated with obesity and breastfeeding and diabetes and all the prenatal factors that are associated with it. So we wanted this opportunity for our patients to consult our lactation consultants anytime that they wanted. So they can call on this hotline any time of the day and get a consultant online and help them with breastfeeding. That's our pediatric dietitian on the left and our pediatric wellness coach, Trevon, on the right with two of our patients. This is our pediatric life coach program that we started last year. It's a 12-week program for patients ages 6 to 17 who have either been diagnosed with prediabetes on labs or have signs of insulin resistance on exam. The pediatric dietitian provides education based on my plate and the food label. They focus a lot about how these kids can buy these foods and learn how to read that label so that they can have some healthy lifestyles. And the pediatric life coach provides mentorship along with education on exercise. The first 4 weeks are basically assessment and acclimatization. They fill out a survey called as the 5-2-1-0. 5-2-1-0 is 5 servings of fruits and vegetables, less than 2 hours of screen time, 1 hour of physical activity, and 0 sugar and sweetened beverages. So we assess that before they start this program and at the end of it. And they do a fitness assessment. Squats, lunges, and planks are the most common ones that they use to assess the fitness levels. Based on where the patients are, we try to build a program around that. Weeks 5 to 9, they focus on nutrition education, resistance, and plyometric exercises. I won't go through all of them that are listed there. And then week 10 to 12, we do post-assessment and fun physical activities to kind of wrap up the program. Patients are more than welcome to continue with our life coach, not necessarily follow this curriculum, but just keep working out with our trainer. They usually come in and see the trainer once a week. If they can't come in, we do provide a virtual platform for them to connect up. And then they see the dietitian at least 4 times during this 12-week period. Here are some of our success stories. We had a patient whose A1C had lowered down from prediabetes to normal glycemia in just about 6 weeks. And one of the patients lost about 5 pounds, another one lost 10. So patients are really motivated to be in this program because they see them so often and we try to make it fun for them. Impacts of COVID-19, we did, all, like any one of us here in this room have been affected with how do we provide this care to these patients. All our patients have been offered virtual learning platform. Through a separate grant, we were actually able to provide HP touchpads to our patients to connect up with us during this program. They could keep it after the program was over, so a lot of families was able to be in that program. We also had a grant from Nike to provide them with basketballs and goals. Our trainers actually went to our patients' homes to install these goals and did a weekly online program with them and taught them how to play basketball. It was quite challenging, but we did it. And then we did a lot of cooking classes at home with whatever we could find in the pantry. Those are my 2 older ones that made, they called it the peanut butter oatmeal power bombs. So it was quite fun. And shamefully admit all of those were gone in 5 minutes. Total payment fail. These are our spring programs that we did last year. That's our basketball program. The OKC Thunder was kind enough to partner with us as well, and they provide tickets for our patients to go and watch the game once a year. So if you're in this program and you've successfully completed it, then you go do that. This is our martial arts camp. These are the cultural camps that we did through the summer time. This is one of the biggest camp that we do. It's called as the turtle camp. It has got nothing to do with the turtle. It's basically, it's a big mnemonic. I'll spare you the trouble for it, but it's basically lifestyle explanation to our patients. But it's a day camp. It's a 3-day camp. One of us, either me or one of my pediatrician colleagues, go and attend the camp the first day or two to screen our patients for obesity, hypertension, and acanthosis. And it's a good process for us to screen these patients and get them into our clinics as well. And then the rest of the day, they just have fun. We have partnered with the river sports downtown, and some of these kids don't even have the opportunity to ever go there, but through these partnerships, we are able to send them over there. We also do a dance camp for the female patients. In the picture right on the left, we actually had Miss Native Oklahoma come in and visit us and encourage our patients to do this. But they do a lot of cultural dances and teaching during these camps. We have our sports camp with basketball, soccer, and then this is another turtle camp that we had in July. And then we had a swim camp with a partnership with Goldfish Swimming School. And then this is what we call as the Kids in the Kitchen. We use the same kitchen that we use for our adult patients to teach our children two things. One, we try to teach them kitchen etiquette, how to use knives and forks and spoons and not injure themselves. Second, we try to make all the snacks from scratch and make it healthy. And also very interesting, as you see the middle picture, I don't know what animal they were trying to make, but that looks very interesting. So I'm going to try and wrap this all up with this video. I don't know if this is going to play or not, but if it doesn't, that's okay. It says it cannot open specified file, but it was basically a video that was made by our CEO for the clinic. But that brings me to the end of my talk. Thank you.
Thank you very much, Dr. Dasari. We probably have time for maybe 1 or 2 questions, if there are any. I know really quickly you've had some great success. Thinking back from when you started, how much has your practice increased and changed, and what benefits have you seen just in your short time there as a practitioner?
So before I started, we just had general pediatric services, and so everybody was being referred to OU. So I was able to take over the endocrine part of it at least. The Kids Fun and Fit area that I was talking about, that is a new program that we started after I started working there, because we had an area for our adults to come and work out, but there was nothing for the kids. So we actually tried and got a grant through one of the CDC grants. We were able to employ a pediatric life coach and get that started. And then the whole pediatric wellness program as well.